Hi everyone, my name is Esther. I am a GPST1, so I'm my first year of GP training. For those of you that don't know me, I went to Leicester Medical School, did the grad course at Leicester Medical School and graduated in 2019, did F1, F2 in Leicester, worked as a CTF last year, and I'm now GPST1. I'm sure I've worked with you or seen you guys around the med school or as a CTF or through GEM or whatever else, but nice to meet you if I haven't spoken to you or seen you before. So I'm going to be giving you a quick... Oh, sorry, I've got echo. I'm going to give you a quick... it's not really a lecture, talk on top tips for kind of being on a junior doctor on call. It's basically going to be all interactive. So if you guys could interact, that would be fabulous and save me having to talk. I've had to talk to patients all day. So I don't have the chat up. So if somebody from the committee could just shout out if there's any answers in the chat, but otherwise just turn your mic on and shout out. Really, it's really true. I really don't care if you get it right or wrong. Actually, it's not really a right or wrong kind of situation. Okay, so different types of on-calls that you can have. So I'm really sorry if this is different in different deaneries. I don't know who's planning on staying in Leicester, but I've done all my training in Leicester. I have done a few locums in Northampton and elsewhere, but bear with me because it's going to be very Leicester based. So the different types of on-call shifts that you can have these are just a few. So firstly, you may be covering the acute wards. So those are the wards that kind of are between, I'm sure you've all seen them, forgive me if I'm just telling you stuff you already know, but the acute wards are those wards between A&E and going up to the wards. So in Leicester, those are your AMU shifts, your AFU or your EFU, which are basically your frailty units, but they're essentially the same thing. ACB, which is like critical care, so it's very similar to ITU, apart from the fact that they can't manage the airway. So as a junior, you may be placed on that shift, or GPAU, which is kind of like again somewhere between GP and hospital. So patients that need investigations, for example, but maybe don't warrant going to A&E and waiting. The other alternative is SAU, so the Surgical Assessment Unit, which again, I'm sure you guys have seen in your rotations as medical students, but that's the Surgical Assessment Ward. So basically in the acute wards, you're going to be clerking patients, you're going to be seeing them, you're going to be taking histories, examinations, doing their pro formas, making a management plan and then presenting them to seniors. You're pretty well supervised, to be honest, in those shifts. And I'm sure you guys have done loads of clerking before. So that's your acute wards. Then there's ward cover, which I think most people get worried about. I know that I was definitely the most worried about going on to ward cover. That's basically where you tend to hold a bleep or you have nerve centre phone and you're basically the doctor on call for all the, select few medical wards and also surgical wards. You may also be the bleep holder. So by that, I mean, if you, for example, on stroke rotation, which I'm going to next, I will on some days hold the stroke bleep or like the RAP bleep, they call it. So basically, if there's acute stroke in the hospital, I will have to go kind of stop what I'm doing the day and then go to the call. The same with the cardiac arrest bleep as well. And then there's this new thing in Leicester, but it's kind of going to be an emerging field really, but ED in reach. So you're kind of going to A&E and seeing the medical patients who are just basically waiting for a bed. So you're basically doing AMU, but the patients are in ED. And that's just unfortunately the way that the NHS is at the moment. So those are the different types of on-call shifts that you may have. And obviously, because by the nature of what an on-call is, you're covering out of hours shifts. So that may be a weekend shift. It may be after 5 p.m. So you may do, on some shifts, you may do like a normal working day on your base ward. And then 5 till 10, for example, you may go off and do an on-call shift so on top of your normal working day. Also bank holidays, Christmas coming up and all the bank holidays that go along with that. And also night shifts. So any out of hours shifts are covered by the on-call doctor and a team of on-call doctors. Now, remember, you're always in a team. So even if you feel like you're alone, you aren't alone. Yes, there are less staff, and yes, you may not see a doctor on the ward sitting next to you, but there is another doctor more senior than you in the hospital on every type of on-call shift. So yeah, never feel like you're alone, never feel like you're abandoned. Even if you're out in like a DGH, there's always a senior around, or another F1 or an F2 around. So don't panic. So I just wanted to find out from you guys, out of all those on calls that I've spoken about, or maybe some other ones that you've heard of, which on call shifts are you most worried about doing? So if your final year, doing next year, or otherwise, just shout out so that I know. We'll type it in the chat either way.
I think probably ward cover.
Okay, so somebody said ward cover, which I think is a very fair shout. Anyone else want to further ward cover, or agree that they're worried about ward cover, or tell me why they'd be worried about ward cover, just so that maybe I could give you some advice or dispel some myths about ward cover.
So we've got a few on the chat as well. So we've got obs and gynae night shifts.
Okay.
We've got carrying bleeps in general.
Okay.
Another ward cover as well.
Okay.
And just nights in general.
Okay, fine. So thinking around those sort of shifts, what is there anything in particular that worries you about being on any of those shifts? For example, on a night shift, is it that you don't know how you'll like physically adapt to that, or you've never done a night shift, or is there anything that you're particularly worried about? And honestly, I feel like psychologically getting your head around doing on calls is half the battle. The medicine is actually about 50%, and being psychologically in the game is another 50%. And I've been there, probably been through every emotion possible. So
we've got sort of like being alone, which I think you covered already, and not knowing sort of when to ask for help or who to escalate to.
Okay, so those are some really, really good. But firstly, thank you for sharing, because I think it's so important to share, because something you'll learn really early on in medicine is basically it's all quite overwhelming when you start as a junior doctor. You know, doing just even prescribing your first paracetamol or doing anything is really, really overwhelming, because you've gone from in a position where you're just observing to actually you are the doctor now. So I completely understand that, and that's a really normal emotion to have. Also, I think just acknowledging that you're going to be anxious and it's okay to be anxious is kind of half the battle. But yes, you are never alone, like I said before. Honestly, there is always a senior in hospital, and if you're ever concerned, if you ever feel out of your depth, even if you're pestering your registrar or your SHO or your consultant, just ask the question, because they really do expect you as an F1 to not really know that much. So anything that you do on top of that is a bonus. So honestly, don't feel worried about asking. It's much better that you ask than kind of suffer in silence. With night shifts, I don't know if it's kind of being alone or being isolated that you worry about, for whoever said it or whoever's thinking it, but night shifts are difficult if nobody has ever done one before. I don't thrive in a night shift. Some people love doing them because they feel like they are I don't know, just some people really like it. But sorry, my dog is just here, just annoying me. The good thing about doing a night shift, and the good thing about doing things like ward cover and doing these shifts where you are a bit more autonomous as a doctor, is you actually get to practice real medicine. And that's not to say you're doing it by yourself, but after, you know, being on the ward for a bit and realizing that you are just a bit of a jobs monkey, unfortunately, you're doing basically whatever your consultant kind of tells you to do, it's actually really nice to have a bit of confidence and just go and do some medicine. So you go and make your plans, and then, you know, if you want, you can discuss them with your registrar. So even for somebody like me who, you know, I want to be a GP, I don't like night shifts. I hope to never do a night shift as a GP, but just always try to see a positive. There is a positive in sort of every shift. But yeah, I completely appreciate all your worries, and I probably shared most of them. Okay, so on that note, I think ward cover is probably the shift that most people would worry about, because it's kind of the most rogue, where you get the most random requests to do. So that's the one I'm going to focus on today, and kind of talking through different scenarios on a ward cover shift and saying, you know, what you guys would do basically. So I don't know if you guys have seen in Leicester, I hope you have, but we all have a nerve centre phone, which is basically an iPhone. It's just an iPhone that the hospital owns basically, and all the jobs that either a nurse or another doctor or whoever want for you to do, they put onto the phone. So they will basically kind of like put it through nerve center system, and then it pings up on your phone, and then you can either accept or reject them. And you have to accept them, because if you reject them, it will just come back to you. So you accept and reject your tasks that will all come to you, and then it's all in one place basically. And then the bleep is this thing on the right. So very archaic, but this bleep that will either ping up with a number that you have to call back, or more commonly, it's just like the cardiac arrest bleep. So it'll just go off, and then you go to whatever ward it tells you to. It just suddenly starts speaking to you. It's quite weird. But having said that, I know somebody said they're worried about bleep holding. You're one of a team in a bleep, in an emergency. So even on the stroke wrap call, or if you're in an arrest scenario, you are surrounded by a team. They just want you to do a task. So for example, as the F1, realistically, you're going to be getting the bloods basically off the patient, and if you can, you're going to be trying to cannulate them. So that's all you have to do most of the time when your bleep goes off. So don't worry too much. Right, so this is not like an official thing, but my personal approach to approaching an unwell patient. So imagine I've had a nerve centre request to come and review this EWS 10 patient or whatever, is to do the following. So in my head, I will say, right, okay, so I need to do an A to E for this patient. We know that's how we acutely assess patients. And if they're conscious, or if it's appropriate, I will also do a history to find out a bit more. After that, or maybe even before, if pertinent, I will look in the patient's notes. So remember, this isn't an OSCE. You have the patient's notes. You have lots of things have already been done. Your job is not to start from scratch. It's just to sort of fill in the blanks and see if you need to change anything overnight or out of hours. Your job is not to fix this patient. Your job is just to keep them alive until the normal doctors come on in the daytime, or whenever it's going to be, okay? So yeah, I assess them, doing an A to E and doing a history. I then look in their notes and try to get a bit background about this patient. So I want to find out about their past medical history. I want to find out about their drug history as well. I really want to find out about their reason for admission. So why are they in hospital? Is it linked to their deterioration or not? And what has been done in hospital, and what the last plan was from the day team. So very often it will be like, carry on antibiotics, if deteriorates overnight, do X, Y, and Z, which is great, because then you have a very clear plan. And importantly, I want to find out what their escalation plan is, and if they have a DNAR in place. Really, really important to know, especially if being asked to see an unwell patient. Even if that patient is fine, then you want to have an idea of, I write them in my little like list of jobs to do, and I'll just make a note so that I remember, and I also remember they have a DNAR. In terms of the escalation plan, for example, some patients may not be for IVs, or it may be if their cannula falls out, they are not to be cannulated again. So really important to think about those sort of nuances within their plan. After that, I want to think of what are my differential diagnoses based on everything that all the information I have so far. And then I'm thinking about, do I need to do anything else? Do I need to change their management? Am I carrying on the plan? Am I ordering any investigations? And finally, do I need a senior to help? And I can't stress enough, if you need to, just ask your senior. There is always somebody there to help you. Even if it's not your registrar, it may be like the nerve centre coordinator, it may be the DART nurse in Leicester, it may be an SHO, it may even be the consultant if you're finding that people are being obstructive. And remember, I've done this before. I felt like people weren't helping me, so I've called a peri-arrest on a patient, and then the whole cardiac arrest team have had to come, which that patient then did go on to arrest, and they were very grateful that I called for help early rather than waiting for that patient to arrest. So there's a whole spectrum of people that you can call for help. So yeah, that's my just kind of general approach to how I assess an unwell patient and what I would actually do when I go and see them. So based on that, I've come up with a few different scenarios, and these aren't fake scenarios. Most of these scenarios are ones that I've experienced as a junior doctor, and these are sort of the common requests that I have had on a night shift or an out of hour shift. I'm really freaked out about, because I've been like, this isn't a straightforward thing like prescribe antibiotics or prescribe their regular medication. This is something I actually don't know how to sort out, and I've had to figure out during my night shift. So I thought we could talk through some of these scenarios, and I could talk you through my rationale between how I problem solved, because that's essentially what you need to know how to do. So imagine remember I talked about that nerve center phone. I talked about all those different tasks coming through to your phone. Imagine these are all your tasks that have come through, because they tend to come through all at once at the start of your shift or periodically through your shift. So imagine you've got all of these things to do. I want you to tell me what you want to do first as a doctor. So you're the on-call doctor, and again, there's no necessarily there's no right or wrong prioritization, but it's really important to start to think, what am I going to do first? What am I going to do last, basically? So the tasks you've got through, and they're normally really vague, are you've got to fall in the toilet. So a patient has fallen over in the toilet. You've got to chase some bloods, which is very common. You have to do as the on-call doctor, chase some bloods that the day team have done. You've got to prescribe some medication. Sorry, ignore my dog. You've got to chase some more bloods, and you've got to deal with a patient who's vomiting. And then finally, you've got to deal with a confused patient. So based on that, and I appreciate that's not much information, what would you want to do first? So I put them in colours. Sorry, I'm just going to close this door. I put them in colours so that you guys can either shout out the colour that you'd go to first, or you can type in the chat. So which colour would you go to first? Which one would you want to triage as a doctor? Because that's a big part of doing the on-call shift.
So we've got one that says vomiting.
Okay, vomiting. Anyone want to change that? Anyone want to do anything different than vomiting?
We've got one that says fall in the toilet first.
Okay, fine. So fall in the toilet and vomiting.
Another one for vomiting. So airway could be compromised, they said.
Okay.
And another one for fall as well.
Okay, so it's kind of equidistant between fall and vomiting. So Sarah, which would you go to first, seeing as we've got a 2-2 split?
I would have said fall in the toilet first.
Okay, fine. So deciding vote, we'll go to the fall in the toilet first. It doesn't really matter. I agree. It could be either of those two things. So let's go to the fall in the toilet first. Okay, so this is our history. We've got a patient. When we look a little bit more into the nerve center request, because sometimes, if you're lucky, they have a bit of a blurb to kind of tell you what's happened. So this patient has fallen in the toilet, and you look into the notes and you find out that the patient was walking to the toilet and they slipped on their IV stand in the toilet. Really, really common. IV stands are such a trip hazard. It was unwitnessed, so nobody was there with the patient. The nurse has said on the nerve center request that there's no evidence of any head injury, but they've started to do neuro-obs anyway. And they've also written that the patient is on apixaban. So that's all the information that you have. So then you go to see the patient. So this may be easier to shout out for, but equally you can type, but I would encourage you to be brave and shout out. What are we going to do using my approach? What are we going to do first when you go and assess their A to E? So obviously we're going to start with airway, breathing, circulation, disability and exposure. But what sort of things are you worried about in your A to E, and would you want to check on your assessment of this patient?
Blood sugars, like they could have had a hypoglycemic episode, which caused them to fall.
Okay, really good. So you want to check their blood sugars, that's true. So in your disability. So you're thinking about the cause of the fall, which is really important.
Pupils, whether they're reactive.
Okay, and why do you want to check their pupils? What are you worried about?
Like intracranial hemorrhage.
Okay, So you're thinking about, have they fallen, have they actually hit their heads, and is that causing neurological findings? So yeah, pupils is one of the things. So if we're going down the neuro side of things, apart from pupils, what else would you want to check if you're worried about neurological deficits?
Like AVPU?
Okay, so their GCS, so AVP or GCS, either one, yeah. So their level of consciousness. So we've got level of consciousness, and we've got pupils. What else in our neuro? It's kind of what they do in neuro obs, but what are we going to be looking for when we do our own assessment?
Like motor function, so like any reduction in power, either side comparison, and sensory as well.
Yeah, good. So we're thinking about their power, their tone, their sensory deficits. We're kind of doing like a neurological assessment of the patient, right? So those are really important things. Those are some of the main things you want to find out in terms of neurology. Apart from that, what else are you looking for in your A to E of this patient? So apart from neuro things, patients had a fall.
Like postural hypertension, so you want to do like lying and standing BP and ECG as well. Okay,
so yes, you would want to do that, and I agree, but your patient's on the floor, so I may not necessarily want to be doing a lying standing straight away. But I agree that you would want to check that could be a reason for your fall. So yes. Anything else that has anyone heard of a primary survey that you do in patients, normally with trauma patients, but you equally do it for patients who are injured? Has anyone heard of that before? You can say no if you haven't heard of it before. I don't know if I had, actually.
Is that like exposure from head to toe, assessing for injuries?
Yeah, so it is very much the head to toe, but the point of a primary survey is you basically check every joint from head to toe when a patient's come in. So you'll see it in A to E, you'll see it in A and E, not A to E. You'll see it in an A and E scenario when patients have come in after some sort of trauma or fall or whatever. But really important, we don't forget to do that in hospital too. Remember, a fall from standing in a geriatric patient is classified as it's enough to warrant like a trauma CT and all that kind of stuff. So it's significant in that age bracket, given we don't know what the demographics of our patient, but important to remember. So primary survey, you want to check the patient basically from head to toe, checking every joint. So head is obviously a big thing. We'll talk about head in a second, but you want to check all their joints to make sure there's no trauma. So you want to try and move the joints as much as possible, and you want to also palpate along the bones. So all the bony points you want to palpate down, paying special attention to things like the hip and the tummy. Now, why would I be worried about why could I be worried about the tummy? I agree that probably a bit of a exaggeration in this patient, but why could you be worried if a patient came in A&E and you were doing a primary survey and you know that they had trauma on a Pixaban as well?
Like ruptured AAA?
Yeah, exactly, splenic rupture. So you want to make sure, or any intra-abdominal bleeding really. So yeah, you may want to make sure that you feel the tummy. So that's your primary survey. Basically, you go from top to toe. Obviously, in most cases, if they've come from outside of hospital, you want to make sure that you want to check their C-spine first of all, and make sure that their C-spine is safe. And if not, you put them in column blocks and all that. But ignore that for the case of this case. Just imagine that you've cleared their C-spine. So yeah, you want to do the primary survey because you want to make sure that there's no injuries that the patient has sustained in your exposure, but also as part of your A to E. So it's a bit more than exposure, if that makes sense. But good. So we've talked about sort of what you would do and the investigate and the examinations that you'd want to conduct. But thinking about the causes for the fall, which generally you guys are really good at. So medical students are generally really good at thinking about causes of fall. what kind of causes? So we talked about hypo, we talked about postural drop, which is very true. What else could cause somebody to fall? A patient in the hospital.
A mechanical fall.
Okay, mechanical fall. So very true. This patient was walking to the toilet, connected to an IV drip, middle of the night, didn't see something and could fall. So mechanical fall, good. Anything else? There's lots of things that could cause a fall. So just reel them out. There's loads of things. You could probably say most things could cause a fall.
We've got vision problems in the chat.
Good. Vision problems, especially at night time.
We've also got vertigo and neuropathy.
Okay, good. So vertigo, yeah, definitely. If you get up suddenly and then you've got dizziness or any sort of dizziness, but yeah, vertigo. And neuropathy. Okay, good. So if you think about proprioception, if you can't feel the floor, etc. Good. Think about acute things that could cause people to have a fall.
Stroke, TIA.
Yeah, good. Stroke. So that's a big one. So you want to, especially in your neurological examination, you want to make sure, are there any further deficits? Are they slurring the FAST symptoms, remember? FAST. So do they have any facial droop? Do they have any slurred speech? Do they have any limb weakness? Do they have ongoing nystagmus? Because thinking about cerebellar strokes as well. So yeah, stroke's really good. And did you say something else as well? Sorry. You may have just said stroke, sorry.
TIA is a stroke.
Yeah, okay, fine. So TIA or stroke. So they, even if it's a TIA, you'd suspect in that sort of time period, you would still see some neurological signs. But yes, really important not to forget in hospital. Because remember, all these acute things could happen to your patients who are in hospital.
We've got seizure as well in the chat.
Good, seizure. So again, thinking about how you would ask that, what kind of other symptoms that the patient may have, how you would know the types of injuries you would look for, all really important things to bear in mind. Anything else? One main system that I don't think we've mentioned so far that you'd be worried about, sudden onset of sort of loss of consciousness, I suppose, syncope.
Like aortic stenosis.
Yeah, good. So any cardiac causes, really important. So you want to ask the patient, did they have any chest pain before the fall? Was it like a sudden onset? They had no warning symptoms, and the next thing they realised they were on the floor. Very classical for cardiac history, or any palpitations, and all those things are very useful to know in a cardiac syncope. Definitely really important. And actually one that I think I probably didn't appreciate as much when I was in medical school, but important to remember. Good. So I think we've talked about, the only other one important to remember is you're in hospital, most of your patients are geriatric, so delirium. So were they just confused at the time? And delirium in itself, yes, probably wouldn't cause a fall, but it would predispose somebody to fall. Okay, fine. So we've talked about lots of different causes of the fall. So we kind of talked about our differentials, to be honest. But again, on our A to E assessment, so when we're assessing the patient, what you need to start thinking about when you're thinking in the mentality of a doctor is, okay, so these are my differentials. Now, on examination, what are the worrying things that I'm looking for, or what are the reassuring things that I'm looking for? So what things what do you want to check on your examination, apart from the things we've already said in our basic A to E? If that question doesn't make sense, then let me know.
Yeah, sorry, can you explain it in a different way?
So what I mean is, so now you've thought about all these things, you're walking over to this patient, you're thinking, okay, these are my differentials, these are the things I need to check. Now you physically get to your patient. How are you going to, on your assessment or your history, how are you going to check whether the patient, how are you going to reassure yourself that these things haven't happened to my patient. So for example, what am I practically gonna do to reassure myself that this patient hasn't had a stroke, or hasn't had cardiac syncope, or hasn't had a seizure, or on your examination, or on your history, basically. So let's go through each one in turn. So stroke we kind of spoke about, so lack of fast symptoms, basically. So you should see some sort of neurological deficit. What are you going to do on your A2E and in your history about asking about cardiac syncope? What kind of things may help reassure you that this patient hasn't had that?
Ruling out sudden onset palpitations before the fall, or were they exerting themselves before the fall?
Okay, good. So those sort of prodromal, so if they do have a prodromal symptoms, not all of them do, like I say, but yeah, okay. Any cardiac symptoms, and we said chest pain earlier. What else in the history may point? Sorry, not history. Apologies. What else in your A2E are you going to do? I think someone said it earlier. That's going to say, okay, something cardiac is happening, or something cardiac isn't happening at this time.
ECG.
ECG, good. So ECG, and what else? What could you do in your bloods as well, just to make, if you were suspecting ischemia, what else could you do?
Troponin.
Yeah, good. So troponin. So that's your cardiac history. That's how you're going to think about your cardiac syncope. So then we think about hypoglycemia. Very simple. You're going to just check the BMs. And then what else did we say? Seizures. How are we going to find out, has this patient had a seizure? What are we going to do either in our investigations or our history, in our A2E or our history?
Tongue biting, incontinence, and like a long post-ictal confusion.
Okay, good. So it's like those classic symptoms that we know about. Say it was completely unwitnessed, and the nurse, it's fine, they may find them post-ictal, but say they were completely unwitnessed, they just found them on the floor, and they were talking to them, and you don't know. You could look for incontinence and tongue biting and things like that. What else could you do on your A2E? What could you look for on a blood test that may point towards a seizure? Anything on your venous gas that may point towards seizure activity or a previous seizure that you know of?
Is it that your lactate might be raised?
Yeah, really good. So your lactate is a measure of your anaerobic respiration, right? And when you're having a tonic-clonic seizure, you've got severe limb jerking, constant contraction. So you get a load of anaerobic respiration because your body obviously can't, and you're also in an oxygen deficit because you're not breathing properly. So because of that, your lactate straight after a seizure should be raised. So it's also a really good tip in A&E if you're assessing a patient who you think, is this pseudo seizure, which is kind of like a fake seizure, or is this a seizure? You can do a lactate and it should be raised post seizure activity. So yeah, that's really good. So lactate can be useful, which is really useful if it's completely unwitnessed and you have no idea, because the patient would have no idea. They just say, I was a bit confused afterwards, I don't really know what happened. Good. Also blood in their mouth. Somebody may have said tongue biting. That's really useful. Okay, so I think those are the main sort of things that you could find out about the way that you could investigate and start to think about, how am I going to find out if this patient has had one of these things that has led them to have a fall. But regardless, this patient's on apixaban and they've had a fall. What thing are we worried about? Apixaban being a blood thinner, sorry.
Intracranial bleed.
Yeah, good. So you're really worried about any neurological deficit caused by head injury, right? So you're worried about head injury and intracranial bleed that is leading you to have some neurological deficit, and especially if they're on apixaban. So that's something that you worry about. So imagine you're on call. It's like 2 a.m. in the morning. You've seen this patient. You don't know what to do. You don't know whether you should CT them or you should not. What are you going to refer to? How are you going to remind yourself of whether you need to CT the scans patient or not, or what you're going to do practically?
Do you mean like there's a nice guidelines pathway for ordering a CT head and whether it's appropriate or not?
That's exactly what I mean. I mean, if you don't know whether this patient needs a CT, you're going to go to the NICE guidance. You're going to look up CT guidance post head injury, and you're going to look and see, does your patient meet any of those criteria going down the flow chart to warrant a CT head within 1 hour, a CT head within 4 hours, or no CT head at all. Okay. And you can just write that in your notes, basically saying, refer to NICE guidance, no CT head required, or as per CT head, 1 hour CT needed. And you can use that in your request form. So if you don't know, just think about, how would I have known this in med school? Just think laterally. Equally, you could also call your registrar if you really needed to, or you could also call the radiologist if you really needed to discuss and say, look, I don't know whether this patient needs a CT head or not. But NICE would definitely be my first port of call. Good. So this patient had a very clear history that they didn't have that sort of history. They hadn't hit their head. It sounded very mechanical. It sounded like they got tangled in their IV cord. They didn't put the light on and they'd fallen over, basically, and then they made their way back to their bed. Has anyone seen the fall sticker in UHL? I don't know if those of you on the ward have seen those big yellow stickers that you have to fill in as a doctor. Don't know if anyone's seen that. If you haven't, next time you're on the wards, I would just pick one up because they're so useful for exams. Basically, you stick it in you go and assess your patient, you do all these things that we've talked about, but you stick it in your notes, and it's kind of like a pro forma for a fall. So you cannot forget. Falls are probably the most complicated things you do on a on-call shift, because you're kind of doing it by yourself, and it's like a complete holistic examination and history. So the fall sticker reminds you of all the different categories and makes you kind of go through each question, and makes you ensures that you kind of guarantee that this patient is safe to not to be left alone, or to have neuro obs, or to have a CT scan, basically. So definitely have a look at that in hospital. It's a big yellow sticker. It'll be in most geriatric patients' notes because they mostly would have had a fall on the wards. Okay, so but by this case, what I wanted to show you guys was, you go to a patient, you think about your kind of differential diagnosis, you think about what are the worrying things that I need to consider in this patient, and what you need to start to, and you guys already know that, I'm sure you do from medical school, but now what you need to think about is, now I have that differential list, what am I going to do with it? How am I going to assess my patient to make sure that they don't have a seizure, to make sure they don't have a anything ischemic, to make sure they don't have a stroke? Because that's how you reassure yourself and your seniors and the patient that your management is correct. Okay, so that is the fall. So this patient was fine. They had just had a mechanical fall in the nighttime. Okay, so that's that patient. Where do you want to go to next? I think it was vomiting, judging by what we were saying before. Oh, and senior help if you needed it. Sorry, I don't have like I don't have a quick way of flicking these slides to finding it, so I just have to find the right slides. Okay, vomiting. So you finish that fire, you put it out, document it in the notes, whatever you've done, you reassure the patient, reassure the nurse, give him some analgesia if you need, you move on. Have a sit down, gather your thoughts, have a cup of tea if you need, and you move on to your next patient. So your next patient is vomiting. So again, you look into their notes and you notice, okay, so this is a 70-year-old post-chemotherapy for bowel cancer. So they had chemotherapy today and now they're vomiting, and the chemotherapy was for bowel cancer. You can look at their drug chart, and the drug chart says that or the nurse tells you that they've tried PO, which means oral cyclizine, which is an antiemetic. The patient's been vomiting for the past 6 hours since their chemotherapy, and they've been unable to keep anything down. Okay, so then we go on to, in the same way that we did before, we go to our patient and we want to assess them. So again, let's think about our differential diagnoses first, because I think that in your kind of stage, it's the easiest thing to think about. So we've got this chemotherapy patient. Let me go back to it. Chemotherapy patient who's vomiting. What things are we worried about in this patient? What are our differential diagnoses? I'm going to see if I can open up the chat on my phone in case any of you are posting. But equally, just shout out if you want to.
Just side effect from the chemotherapy.
Okay, good. So very normal, isn't it, to have vomiting post chemotherapy? Yeah. What else?
Worried about dehydration and AKI.
Okay, so we're worried about dehydration. That would be like a consequence of the vomiting. But yes, we definitely need to think, okay, if they've been vomiting for 6 hours and they haven't kept anything down, could they be dehydrated? Absolutely. What else could cause their vomiting? Or what else would you be worried about?
I was thinking along the lines of maybe like a bowel obstruction. Depends
Bowel,
what they've had
yeah.
for their bowel cancer.
Yeah, really good. So we really need to think about that with bowel cancer. Have they may have been on the cusp of going into bowel obstruction, so they may have gone into bowel obstruction. You also have to think, okay, it's not normal for patients with chemotherapy to stay in hospital. So why is that? Was it because they were persistently vomiting, or was it because their bowel cancer was so advanced they were worried about obstruction or something? So yeah, really good. Obstruction. One other thing I would say I'd be worried about for a patient who's vomiting post chemotherapy.
Could you have like neutropenic sepsis, maybe like caught a bug or something?
Yeah, absolutely. So neutropenic sepsis, again, I apologise for those of you who haven't done cancer care because it's a very specialist diagnosis, but just as a real overview, basically if you have chemotherapy, it obviously completely obliterates all your white cells, so you've got no neutrophils to fight any infection, hence neutropenic sepsis, and then you get an infection on top of that, and then you get neutropenic sepsis, and we really worry because you've got no immune system to fight anything, basically. And there's a criteria that you'll learn down the line. Yeah, so absolutely, post chemotherapy, okay, fine, the history's a bit close, but equally you don't know where in their chemotherapy they are. They may be, a day or two into it, a week or two into it. So absolutely neutropenic sepsis. So those were my main sort of differentials going into this, and I was on an oncology rotation, hence this was my daily on-call situation. Right, so going back to what we're going to do, let's start here. So on our A to E, what are we looking for? So again, remember, we've got our differential diagnoses in our head. Let's take all those things in turn and think about how we're going to find out whether they have one diagnosis or another. So neutropenic sepsis, what we're going to do on our examination or history to disprove that they've got neutropenic sepsis or prove they've got neutropenic sepsis.
Do a full blood count and take their temperature.
Yeah, good. So signs of infection, and are they even neutropenic? So they may not be neutropenic. Good. And then we said bowel obstruction, what you're going to do, what kind of things you're going to look for to see is this patient in bowel obstruction on examination and on history.
Absolute constipation.
Absolute constipation. Absolutely. Do you see what I did?
Like likely abdominal pain.
Yeah, okay, abdominal pain. And what else about that abdomen?
Like tinkling bowel sounds.
Tinkling bowel sounds, okay. And genuinely, I heard tinkling bowel sounds for the first time last year, and it sounds tinkling. It's one of those things that you're like, oh, okay, that is actually an apt description. Tinkling bowel sounds. And what else about their abdomen? What does it look like?
Distended.
It looks distended. Good. It looks really distended. Sorry, I'm not being rude. I'm just trying to join the chat on my phone to make sure that people are involved if they want to be. Good. So that's your bowel obstruction. And then the last thing is chemotherapy sort of related. And again, you're not really going to be able to tell. That's kind of like diagnosis of exclusion, really, isn't it? Okay, so you've done those things, you're looking through the history, you're still not completely clear where things are going, there's no signs of bowel obstruction, you're waiting for the bloods to come back, but certainly the bloods pre-chemo didn't show neutropenia. So less likely, no signs of infection. On your A to E, so somebody mentioned dehydration. Is there anything else that you'd be maybe conscious about with somebody that's persistently vomiting apart from dehydration?
Metabolic alkalosis.
Good. Audio. There you go. I've got the chat now, I think. So by the way, if anyone wants. Metabolic alkalosis. Okay. So, yeah. That's a long-term kind of change, but in the short term, what else are you worried about?
So, Mallory Wise tear.
Okay, Mallory Wise tear. So if they're vomiting loads and loads and loads. Anything else? That can happen if a patient who's, imagine geriatric, persistently vomiting, lying down in a bed.
Aspiration.
Aspiration, absolutely. So that is the thing that I worried about the most in this patient, because in frail patients anyway, because you don't have the ability to sort of heave in an upright position. So that's something I personally really worry about. Okay, so given those things, what are you going to do in this patient in your sort of immediate management? So you've looked in their backgrounds. You haven't really found anything that's that interesting. They're on PO cyclizine, so oral cyclizine. You realise that the reason for the admission is that they were just wanted to be monitored post chemotherapy because they started vomiting straight away. So it's kind of an unexpected admission. No management at present, apart from the fact that somebody has very cleverly cannulated them and taken some bloods for you. And they don't have a DNAR or an escalation plan in place at the moment. So yeah, what kind of things are you going to want to do for this patient practically, given the things that we're worried about? So we're worried about dehydration, we're worried about aspiration pneumonia, and we're worried about their ongoing vomiting, which is obviously not pleasant for that patient. What are we going to do? What kind of management things? I can now see the chat. People
IV antibiotics.
Okay, so IV antiemetics, good. Definitely want to. Ondansetron is always one that I tend to go to in chemo patients. But yeah, IV antiemetics.
Fluids.
Fluids. How are you going to give the fluids?
IV.
IV, good. So you're going to give IV fluids. And what else are you going to do in most patients in the hospital? You will get called to do this. I guarantee you, even though Leicester do not teach you how to do this. Well, they didn't teach us how to do this. And patients that are persistently vomiting.
Catheterize.
Okay, you could catheterize to measure urine outflow. They do teach you how to do that, I hope. But something else. To prevent aspiration pneumonia.
NG tube.
NG tube, good. I don't know, do they teach you to do NG tubes? They didn't teach me.
So I got taught NG tubes, so
all right, Sarah, you
maybe
can do all the NG tubes for the whole ward. Yeah, it's really challenging to do an NG tube when somebody is vomiting, because I mean, nurses are amazing at it, and these are one of the skills that they're all much better than we are at, because they do it much more often. And we don't do that much in medical school, if any. I had done none. I genuinely, in this scenario, none of the nurses on the ward could do it. I genuinely went to the toilet and watched Geeky Medics, how do I NG tube a patient? And then had to NG tube them, which is shameful, but that is one of the downsides of being a doctor. It kind of, you are the last line of defense, so you have to do it. Yeah, so NG tube. Absolutely. So you can also, NG tubes are useful because you can put a bag on the end of it, so then the stomach contents basically just drain out into a bag. You can also, if you don't want to put a bag on it, you can aspirate the bag, aspirate the NG tube, so drain everything from the tummy. So really useful for that. Can you, if I wanted to feed a patient, what would I have to do when I put an NG tube in before I can feed a patient? I can now see the chat. I see somebody said NG tube. Sorry, I was a bit slow. So that one.
Chest X-ray.
Yeah, so you need to do a chest X-ray, and in Leicester, it has to be seen by a registrar. So they have to okay that this chest x-ray shows that the NG tube, why do we do a chest x-ray? What are we checking for before I say?
The location of the tip of the NG tube to make sure it's in the stomach and not gone into the lungs.
Absolutely, because if you're feeding someone, you don't want to feed their lungs, basically. That's a really bad thing to do. So yes, absolutely, you need to get an x-ray. But anyway, that wasn't the case in this patient. We just needed to NG tube them and make sure that they were hydrated. So this is the type of patient which I probably I may alert my senior to. Now, something helpful they do in Leicester is halfway through your night shift, you meet with, or halfway through your day shift, if it's a long day on call, you meet with your registrar and you all kind of catch up and discuss any patients that are worrying. So this is one patient that I may just save just to let them know, oh, by the way, I'm not sure about this patient because X, Y, and Z have happened. Okay, so that's this patient. By the way, I should have said, if anyone has any questions, please just shout out. Right, now I'm going to go back to our initial list. We won't be able to get through all these questions, but that's fine. Where do we want to... sorry, I think that this has gone off screen. Can you guys see that again?
No, we can't see at the moment.
Teams then. Sorry. Clearly I haven't had to do this in a while.
Yeah, there we go.
Okay, fab. So yeah, out of this, where are we going to go to next? What else are you going to do? Where do you want to go next? So we've done vomiting, we've done falling toilet.
The confused patient.
Okay, confused patient. Anyone want to go anywhere else?
Do we know which medicine is being requested to prescribe?
Good question. So we look into it and it says warfarin. Does that change anything or does it not? It may not. Often doesn't for me. No? Confused patient? Okay, we go to confused patient. So I'm going to keep it like this. Just let me know if it changes screen once I get to it. 1 second. Confused patient. Can you guys see that?
Yeah, we can.
Okay, cool. So you've got this confused patient. All you know, patient is calling out on their bed and they're waking up the rest of the bay. So really common. I can't tell you how many times on call I'll get called to this type of patient. So you go to see this patient. You're thinking on the way, okay, so confused patient. I basically want to know, is this acute confusion? Is this ongoing confusion? So this is the type of situation where unless the patient is immediately at risk, I will look in the notes first because I want to know, is this, like I say, a new confusion? So the patient was fine in the daytime and now they're really confused, or is this an ongoing confusion that we actually just need to reassure the ward and we need to reassure the nurse about. So slightly different scenario in the sense that you go and you look at the patient, you see in the notes that they're just delirious, they've got a UTI which has caused them to be delirious. So you go, the patient's just in bed, they're just genuinely, they were singing Christmas carols in the middle of August, which I found amusing. The rest of the bay did not, and the nurses did not also. But anyway, you go and see the patients. They are fine. They obviously aren't copus mentis, so they're not talking to you and making much sense, but their obs are fine. There's no acute concern. So then you speak to the nurses and the nurses say their main concern is that this patient is keeping the rest of the bay up and they're becoming disruptive. So when you're trying to go and give them their medication, they're spitting it out and they don't want to take it. And they really want you to do something. So what are you going to do in this scenario? Because it's really common that it's not really a sick patient you're dealing with. You're dealing with nursing anxiety and also an ongoing issue with the patient. So what practically do you think you'd do in that scenario?
So I would say maybe like try and verbally de-escalate.
Okay, fine. So try to verbally find out what's wrong and what is kind of reassure the nurse. Okay, somebody else was going to say something as well.
Yeah.
Yeah, I was going to say the same thing, but also like check if there's any reason it could be like delirium, like any causes for delirium, like is there infection going on or changes with that?
Yeah. So you want to find out, is there any new cause of delirium? So we know that the delirium in this case is probably due to a UTI, and also the fact that this patient has, like if it's an AMU bed, they've likely just gone into a new environment. It's probably made it worse. In this scenario, when I'm dealing with I know I don't mean this to sound demeaning to nurses or in any way, but if it's another doctor, if it's another healthcare professional and they are concerned, I genuinely use ICE on them. So ICE that we use. So I ask the nurses, I'm like, okay, so is there anything that you think is happening here? What do you think is happening here? And then she literally said, oh, the patient is confused because of X, Y, and Z. So I said, what's your concern with that? And the nurse said, I'm worried that they are keeping the rest of the bay up, and the bay are becoming really annoyed and they're taking it out on me, which is understandable. So I asked her, what would you like me to do about that? Because I can't change their delirium. And to that, the nurse said, I would like you to either sedate them or prescribe zopiclone to put her to sleep, the patient to sleep. Put her to sleep temporarily, not to kill her. That sounds a bit dark. What would you say back to that? What would your rationale for or against? Would you go along with it? Would you not? What would you do?
With haloperidol, isn't it like a form of, what's the word, like restraint to a patient? So if it's just for, like, if no one's in acute danger, like if the patient isn't being aggressive or anything like that, it's just that they're a bit unsettled and disturbing the bay, that's not really an indication for, using a chemical restraint on them.
Okay, that is one way. That's how I thought about it. But anyone want to pose anything else that they would be either concerned about, or maybe you would want to go ahead and do it? Because the nurse is really pleading with you and they're saying, this cannot be my night shifts. I cannot go through this night shift like this. Please, please, please help me. Anything else you could do? Anything else you'd want to say? So somebody in the chat has said polypharmacy issues. Absolutely. They've also said you shouldn't use the least restrictive measure first, which would be non-pharmacological. Absolutely. So I completely agreed with this, and that's essentially what I said to the nurse. I kind of chatted with them and said, look, and unfortunately didn't really reach we couldn't really see eye to eye on this, and I like to think I'm very compassionate at work and try to work with nurses as much as I can, but we can all appreciate, as doctors, we come and go on and ward on call. We are not the person that's having to be witness to that all the time. But my argument to the nurse was that I wasn't going to do it because of a few things. Firstly, as you guys all said, polypharmacy is not appropriate. Like it's you're sedating somebody just because they're causing a nuisance, not because they're causing harm to themselves or to other people. So it's not appropriate. That's number one. Number two, sedation is dangerous in itself. So if something was to happen and the airway was to be compromised, I cannot deal with that situation, and risk versus benefits, you can't justify that really. And then lastly, you can make them more confused. You can make the issue worse. Polypharmacy, as you've said, can make things just spiral out of control. So in this sort of situation, you do just have to stand your ground, and it's a difficult conversation. I like to sort of leave conversations with a nice conclusion, but this was one situation where you just kind of have to, unfortunately, stand your ground and say, look, I personally am not prescribing this. If you have any concerns, you can, I can raise this with the registrar when I see them, but actually, personally, I'm not going to prescribe it. So yeah, good. You will get a lot of zopiclone requests as a junior doctor because patients annoy nurses, which is fair enough, but probably not appropriate. Okay, so we'll go for like another one or two cases, so and then we will wrap up. So where do you want to go to next? So we've done falls, vomiting, confused patients. We've got 2 chase bloods and prescribe warfarin, which we know. I can tell you in the interest of time that one of the tracing bloods is for refeeding syndrome, and one of the tracing bloods is routine bloods, ongoing infection. So where would you go next? Where would you want to go next? It's kind of no right or wrong. Remembering that some of these things you could maybe do remotely if you were able to.
Maybe refeeding syndrome bloods.
Okay, refeeding syndrome bloods. Let's go there next. So refeeding syndrome blood. So these are the bloods you log on, and you can do this. You can do this virtually, which is obviously very useful. So you log on to Nerve Centre and you see that these are the bloods. Now I appreciate I haven't put the parameters on because it's useful to start to think about what's normal, but I will tell you that phosphate is normal because that's probably one that I would also have to look up. Out of these, shout out which ones are abnormal.
Potassium's low.
Potassium's low, good, and there's one more.
Is pH phosphate or
phosphate?
pH?
Yeah, phosphate is normal.
Phosphate.
So you've got a choice between sodium and magnesium. Which of those two is out of range?
Did you say magnesium was normal?
So I said phosphate was normal.
Oh, okay, sorry. I say magnesium's not normal.
Magnesium's low. So magnesium is low. So this is a prime example of where like you're not expected to know everything. Don't worry if you don't know everything. So your potassium and your magnesium are low. I feel like they don't really talk about magnesium in medical school. So definitely was a learning curve in being an F1. What is magnesium and why do I need to like keep checking it? So something I would look up in your own time. Now, firstly, refeeding bloods are obviously if they are when a patient is really malnourished and you're giving them food all of a sudden. In the UK, that's actually very common. I never thought that would be something that we'd often have to do because it's something you learn about in like, third world countries where people are famished. But here, it's for your geriatric patients who haven't eaten or who are eating poorly at home. It's very common that we have to do refeeding bloods. And refeeding bloods, you're basically checking their electrolytes. Those are the most important things. Calcium is another thing that you should check, but I've got to put it on. So we know that the potassium and we know that the magnesium are low. Which one are we going to treat both first? We're going to treat one first. What do you think we're going to do? What would be your management strategy here? What do you think would be useful?
Is it that you can't like if you've got hypomagnesia, but if that's low, then the potassium won't, as much as you treat the potassium, it won't raise up. So you need more. I'm not saying this very well at all.
No, I know what you're saying, and you're saying it exactly right. So you're absolutely right. Magnesium, if magnesium is low, it will draw down. I don't know why. You can look it up, but sorry, my dog's coming. He's ringing low. If magnesium is low, it will draw down all your other salts as well. So it's very common that you may see multiple other electrolytes which are low if your magnesium is low, and they will not be corrected until you treat the magnesium. So you don't even necessarily need to treat the potassium because often it will actually sort itself out once you treat the magnesium. So that's the first thing to say. So yeah, absolutely treat the magnesium first. And I really don't think they talk about it enough at medical school. Another thing is, if you've got a patient on the ward and you're seeing every day that their electrolytes are low despite you replacing them, so you see they're still really hypokalemic every day and I'm giving them IV potassium, what am I doing? Check their magnesium because you may find that it's the magnesium drawing it all down. Okay, so that's the first learning point. The second learning point is what on earth are we going to do to treat this magnesium? You've never had to do it in the daytime. You don't know what you're going to do. This was my first night shift and I thought, I don't know how to treat magnesium. What are you going to do? How are you going to find out this information? You may know this information, which is bonus. I didn't know this. Okay, so somebody has said, Phoebe has said, check the NICE guidance. Very good. That is one place you could go. And I went to the NICE guidance and it was so convoluted that I couldn't understand what it was saying. And it said, follow local policy. So what you're going to do. So magnesium is something that you need to treat overnight as well. Electrolyte disturbances, you should start treatment overnight if it's severe.
Insight guidelines.
Good. So you want to check trust guidance. So you want to check UHL guidance. Now, I'm sure it's the same for most hospitals, but if you Google most things on Insight, which is the hospital intranet, you can find most guidelines on most things. And this is, I think if I click on this, it's actually probably going to take me out of slide sharing, so I'm not going to, but you can Google it at home. You can Google most UHL guidelines and find it at home, which is a great thing. So say you could type it in now, you could type in hypomagnesemia or low magnesium. I think it may even come up with UHL and you should find the guidance come up. It's under like diabetes and endocrine, which is really useful. So I don't know if somebody's been savvy enough to do that now, but anyone know what you do with a magnesium of 0.3? Anyone know what the replacement is, whether it be IV or oral? If you have, you can either guess or you can, if you may be looking at the guidelines, you may be savvy. So I'll tell you, it's late, I appreciate that. You give it IV. And the reason you give it IV as well, remember with magnesium, is loads of these electrolyte, like Sandoz, all these things can give really horrific diarrhea. So if you're in hospital, they prefer to give things IV anyway. So yeah, IV magnesium, and it's all on the protocol. It's all on Insight. Cool. So in the interest of time, I'm going to wrap it up there. The other two cases weren't overly exciting, so don't worry. One was the other routine bloods were following up for a chest infection. So it was just reviewing the bloods that were done in the daytime that weren't back in time. So they've asked the on-call doctor to trace them. And the numbers on the right were the older results. And here you could see that the white cells had gone up, the neutrophils had gone up, and the CRP was about the same because the CRP lags by about 48 hours. So here, in this sort of scenario, you're worried that the infection's worsening, and you may look in the notes and find out that they're already on antibiotics. They're on the things that you would expect them to be improving on, not deteriorating on. So say that they were on oral antibiotics, so they were on oral amoxicillin for a lower respiratory tract infection. What would your next thing be, do you think, if the white cells had gone up and the neutrophils had gone up despite that treatment for a few days? Consider atypicals, good. So you may think like fungals or just atypical organisms for which you would use. So amoxicillin covers most things, but doxycycline covers your atypical. So you may consider adding in doxycycline. That's good. And what else could you do with the amoxicillin? So it's oral at the moment. You may change it to IV. So generally, if you see that an infection is worsening, you want to either add something else into doxycycline, which is absolutely something that I would probably do. And also, you may also escalate the current antibiotic, so change it to IV. So you're increasing the bioavailability of it, which is useful. So you may just consider that. And then also you want to think about, are these now septic and all those things. But just looking at blood results, those are the things that you want to sort of consider. So remember, you're just putting out fires on an on-call shift. You're just thinking, what can I do to make this patient be as safe as they can be overnight? I don't have to revolutionize their plan. I don't need to be ordering like a CT scan unless you think it's necessarily needed. I don't need to necessarily get to the bottom of exactly what organism is going to be causing all these things. I just need to make sure these patients are safe overnight. Yeah. And then the last thing was just the warfarin, which really quickly I'll go through. because it's really common that you have to do it. Warfarin is still a paper chart, which is really annoying. I think this was when I was last in hospital. It was a paper chart. So imagine this is really common. The INR on, imagine today's Thursday. I don't know why when I wrote this clearly it was a Thursday, but on Monday the INR was 2.5, so the dose was 3 milligrams. Sorry, so this patient is has AF. So their target INR is between 2 and 3. So 2.5 is kind of ideal. That's your target range. So on Monday, the INR was 2.5, so they want 3 milligrams. That was signed by myself. On Tuesday, it was 3, which is fine. So you did 3 milligrams. On Wednesday, it was 3. So then you've gone to 3 milligrams. You've kept the doses the same. But today, you've been asked to dose the medication, and actually the INR is 4. What do you think you would do? Because warfarin's a really common one that is a bit tricky to figure out what you would do with that dose. Are you going to give them the same dose? You're now out of range. Remember your dose range was 2 to 3. Are you going to give them the same dose? You're going to omit a dose? You're going to reduce the dose? What do you think you would do, or what you're going to do to find out what you would do?
Would you like check for any signs of bleeding with the patient, and then check if they started on any new medication that could interact with warfarin?
So excellent. Yeah.
If none of that, maybe just reduce it by a milligram.
Okay.
So give 2 milligram instead.
Yeah, fab. So that's exactly right. So you want to make sure that nothing has changed that's caused this INR to be out of range. It may be purely that they've been given 3 milligrams constantly, but actually the INR was kind of on the higher side anyway, and now it's just been pushed out of range. So imagine all those things were normal, they've just been pushed out of range. Yeah, it's sensible just to reduce it by a milligram. So you could go to 2 milligrams and then just check the INR again the day after. Or if you want to be really clever, again, going to Insight and looking on Insight, there is a UHL pathway for anticoagulation warfarin guidelines. And I'm really sorry that I copied and pasted this, but it doesn't come through very well. But basically, you can see 4 is not that high INR, so I wouldn't expect them to be bleeding. But less than 5, so we're going down that bottom pathway. If there's minor or no bleeding, you could either consider stopping or pausing the warfarin, or you could review cause and reduce the warfarin dose and just monitor the INR closely, which is essentially what we said. The learning point from that is that there's no absolute way to manage warfarin. It's just doing something that's sensible and just making sure you check the INR regularly and daily, basically. Right, so that's kind of the end. I really hope that that's been useful for you guys. I appreciate it's been a bit all over the place, but that's kind of what an on-call is like on ward cover. It is just really bitty, and I really just wanted to cover some of the more difficult scenarios that you may have and how you approach thinking about them without panicking and in a kind of logical way, and then also some of the less acute scenarios but then challenging in a slightly different way. So, you know, practically what do you do and how you would go about looking at things. Just one really quick thing, 'cause I want you guys to get home, and you are home, I want you to get on with your evening. Just well-being stuff. So we talk about on calls, and I'm sure you've had lots of talks like this before, but one thing I just want you guys to bear in mind as you go into the NHS is you are the most important person on that shift. Okay, you need to take care of yourself. Yes, you need to take care of your patients, but you need to take care of yourself first, and you need to make sure that you're protecting yourself from lots of, from burnout, from loads of things. Okay, so your physical and mental well-being is really important. So make sure you take your breaks. It can be really challenging on shifts, and sometimes with all good intentions you can't do it, but just try your best to take your breaks. Nobody's going to tell you to go on a break. You just need to do it yourself. Okay, make sure you eat lots of food, you drink lots of water, and you take care of yourself. Don't stay late. Try your best to not stay late. There is the whole reason that you have an on-call system is so that you can hand over to somebody. You're not leaving your patients in the lurch. You are just handing over those jobs to somebody else. And if it's not an acute problem, like it's not discharge, but it's something that can wait till tomorrow, it can wait till tomorrow. You going home is more important than that. Call for help if you need. You are not alone. You're never alone in a hospital. There's always somebody more senior than you, and there's always a colleague that's around. remember that you can only do your best. Despite your best intentions, a patient may die, they may deteriorate, and even you may have, you know, people telling you off. You may have nurses being annoyed at you that you're not there earlier, but you were doing your best, and that is the most important thing to remember and to take home with you when you leave that shift, is that you did your best for that day, and that's okay, and that's enough. Treat yourself outside of work. So as I told you, I hate night shifts, so I will treat myself after that night shift. Loads of people do it. So I finish on a Monday morning, I've been up, I want to do something nice, I will do something nice. I will go to the spa, I'll do something nice. Take care of yourself. You deserve it, you really do. And also just look out for signs of burnout. And I didn't really know what that meant before I started as a doctor. So when I was a doctor, I wrote a piece about it in like an East Mids journal. And the symptoms of burnout are triad. So it's exhaustion, so just feeling really exhausted persistently, feeling like you have reduced productivity, and feeling really cynical about your work. So feeling cynical about going to work and being a doctor in the NHS and all those things. If you see any of those things in you or a colleague, you know, it's okay, just talk about it. It's really common. But yeah, having said that, I'm sure you guys are going to be great doctors. I'm sure you're going to be great med students. I'm sure you are great medical students. If you want to email me, you're more than welcome to. If you have any questions, my email is actually just, so you can email me if you need anything. Otherwise, I look forward to seeing you on the wards sometime soon, and I will hang around for a few minutes if anyone has any burning questions. But I will let you guys go and have a lovely evening.